PGI Chandigarh. We are here to the next session for the ICMR Center for Advanced Research. And today's our topic of session is the grade approach. We have Dr. Anjan Datta with us for this lecture. He is assistant professor in the Department of Community Medicine, Tripura Medical College, and Dr. BRM Teaching Hospital. A very warm welcome to you, sir. Over to you, sir.
Thank you so much for the introduction. Today we would discuss the topic of the grade approach, and if you may allow, can I start sharing my slide?
Yes, sir.
Okay, so give me a moment. Is the slide visible, ma'am?
Yes, sir.
Okay. Okay, so good afternoon all. Today our topic of discussion is the grade approach. By grade we mean grading of recommendations, assessment, development and evaluation approach. Myself, Dr. Anjan Datta, I am an assistant professor in Department of Community Medicine in Tripura Medical College and Dr. BRM Teaching Hospital. Now, the beginning of this discussion is incomplete with this specific slide, where this entire slide shows how the process of grading of quality of evidence, it starts from the PICO format, that is population or patient intervention comparison and outcome, followed by its critical appraisal, then data abstraction synthesis, and then followed by grading of the evidence that has been generated to grading up and or grading down based on various factors, then grading the overall quality of the evidence in the summary of findings table. And until this level, the researchers, authors, their job is finished in a systematic review. Then comes the job of the recommendation or guideline formulation panel, who further makes different recommendations based on the quality of evidence to a strong or a weak of quality of evidence. So this is a very famous picture where two meteorologists, they were discussing amongst themselves. Then why the question of grading of evidence has come? Why? Because if you just see the example, one meteorologist was saying to another one that there is 40% chance of shower today that I predict, and there is 20%, 10% chance that we are sure about what we are talking about. Means there will be 40% chances of shower, but the precision or the confidence on that evidence is merely 10%. Now, talking about grading the quality of evidence, it can be graded into very low, low, moderate and high, and similarly they are represented with 4 plus, 3 plus, 2 plus and plus. How do we do that? The high quality of evidence or high grade of evidence, it means we are very confident that the true effect lies close to the estimate of the effect. The moderate grade of quality of evidence means we are moderately confident the effect estimate that the true effect is likely to be close to the estimated effect. And low quality or low grade evidence means our confidence in the effect estimate is limited. Very low quality or very low grade of evidence means we have a very little confidence in the estimated effect. Now, this is just a sample example just to show you how this grade or approach or quality of evidence grading approach is placed in a summary of findings table in a systematic review. in the previous lectures, we have learned about the systematic review, the risk of biases, then the various formats of doing systematic review, then the summary of findings table. Now, in the summary of findings table, here as you can see various outcomes from several randomized control trials or different studies in your systematic review. They are outlined, followed by their relative risks, then confidence interval, the participants and their details, and then the quality of evidence in grade approach, followed by the comments. Now here in this particular example, you can see the grade for this particular evidence or the outcome of low recurrence. It has been found as moderate. Similarly, for mortality, in an example of HDR versus LDR brachytherapy for oral cancer, it is moderate, and the grade for 3/4 completion is low. So just to understand the quality of evidence or their determinants clearly, whenever we start with grading the evidence of quality of evidence in a summary of findings table in systematic review, at the beginning, for high quality of studies, we usually consider the randomized control trials. The observational studies, they usually begin in our grading system at low quality. At very low quality are the case reports, experts opinion modeling. These are the types of study designs at the beginning of the grade approach. Now the quality of evidence, it is lowered from its initial baseline if there are certain factors responsible. At the beginning of this session, we will discuss the factors or criteria which lower the quality of evidence. First of all, if there is risk of bias. Secondly, inconsistency in the evidence, followed by indirectness, imprecision, or publication bias. Depending on the severity of the bias or inconsistency or imprecision, we lower the quality of evidence into 1 or 2 levels from its original level. In a similar fashion, the quality of evidence from baseline, it can be higher up in low, moderate, or high grade if there is large effect size, if there is dose response relationship present, and if all plausible confounding would reduce the demonstrated effect or increase the effect if there is no effect observed. So if we are through with this particular slide, let us begin with the individual discussion of the factors that lower the individual grade or initial grade of the study design. Variance in study design may produce misleading results, and how does this risk of bias affect the quality of evidence? Now, some criteria has been laid down for randomized controlled trials, which are sequence generation, allocation concealment, blinding or masking, intention to treat analysis or loss to follow up, selective reporting, and some other criteria like stopping trial early for benefit or use of unvalidated outcome measures. For example, patient reported outcomes or carryover effects in the crossover trial. So if based on these criteria, the risk of bias is assessed. For observational studies, the criteria that have been laid down are failure to develop and apply appropriate eligibility, which means under or over matching in case control studies. And then inclusion or exclusion criteria is not matched, flawed measurement of both exposure and outcome, failure to adequately control the confounding, incomplete or inadequately short follow-up. Now, risk of bias may be different for each outcome and are assessed within and across studies. So based on the risk of bias, the grading of your summary of findings table or the quality of evidence, it can be done on not serious, where there is no change in quality of evidence, to serious by downgrading the quality of evidence by one level. So let's say it starts with higher, then if there is serious risk of bias you found, you will downgrade it into the next lower level. Then if there is very serious risk of bias found, downgrade the quality of evidence by two levels. Giving an example with the systematic review on adverse effects of salmeterol on chronic asthma patients. Here, if we just break on the session, it would be population, which is people with chronic asthma. Intervention would be use of salmeterol, and outcome would be the adverse effects of salmeterol. Now, the picture, I'm sorry for the quality of the picture, but if we see to this picture, there are various color codings and systems that has been mentioned. We will just clearly see it here. There are these risk of bias criterias that have been allocated for each study under this systematic review. Here we can see the yellow question marks given means here we are not sure about the quality of evidence. The green plus, it shows that blinding has been mentioned in all the studies here, all the 4 studies that has been shown. And red marks, they show that the free from selective reporting, this criteria has not been mentioned or not been reported in these particular studies. So if we go by this quality of or the risk of bias criteria, out of these 4 studies here, we can see only 1 study actually shows the allocation concealment. All the 4 studies show blinding, and free from selective reporting criteria is reported only in 1 study. Now, this is another way of showing the overall risk of bias. The same 3 criteria for risk of bias have been shown here, and these bars, they show the overall, all the studies included in the systematic review, the overall criteria and their percentage of clear, unclear, or no risk of bias. Now, just if we see here, almost 80% of the studies, they have unclear allocation concealment. Almost all or all the studies, they show blinding procedure followed, and selective reporting is found almost in 50% of the studies. So in the footnote, we'll have to mention that allocation concealment and selective reporting has been done. So if we ask the question, would you downgrade for risk of bias? The answer would be yes. There is serious limitation. Therefore, downgrade the quality of evidence by 1 level. Now, the general guidelines for moving from risk of bias to grade, it is the risk of bias we assess for individual study, and for grade, we grade the quality of evidence across the studies as well. So if there is low risk of bias, most of the studies will show more low risk of bias. There will be no limitations in confidence intervals, and there will not be any effect in the results. So we will not be downgrading the individual level of the studies. If there is low or unclear risk of bias, where most of the studies will have low or unclear risk of bias, here 2 things will happen. Either bias is unlikely to lower confidence in effect, therefore there will be no limitations or serious limitations, so we will not be downgrading the results or our confidence. And bias is likely to lower the confidence in the effect, there will be serious limitations, and downgrading by 1 level would be done. If there is high risk of bias, again most of the studies will have high risk of bias, and critical limitation for 1 criteria or some for multiple criteria, there will be serious limitations for the study's confidence, and we will downgrade by 1 level. and critical limitation for more than one criteria. So very serious limitations and downgrade the levels by. We will move on to the next criteria after risk of bias, that is inconsistency. And inconsistency to lower or downgrade the quality of evidence in grade approach is it refers to unexplained heterogeneity of the results. The true differences in the underlying treatment effect may be likely when there are widely differentiating estimates in the treatment effect. Investigators should explore the explanation for heterogeneity, and if they cannot identify a plausible explanation, the quality of evidence should be downgraded. Now, how to detect the inconsistency in the results? There are certain criteria like differences in direction of the effect from the line of no results or where relative risk is 1. Then large variation in the effect sizes. Then confidence intervals do not overlay. Statistical significance of heterogeneity, where the significance value or p-value is less than 0.05, and very large I-square value. Now, in case of I-square value, there is no such hard and fast rule, but rule of thumb is that if it is above 75% to 100%, it is very large, and below 40%, it is very low. So based on these criteria, either we will downgrade to 1 or 2 level. This picture actually shows there is very minimal overlapping or no overlapping of the confidence intervals. The I-square value is 91%, which is too high, and the p-value is less than 0.001. So first look for explanation. Here in this study, what we can see and we can conclude that there is high heterogeneity present, and if there is high heterogeneity present, based on the previously mentioned criteria, we will downgrade. Are there different subgroups of patients or different effects? Is there intervention similar between studies? Was the outcome similarly defined in the studies? Was the conduct of the studies are similar in quality? These questions we will have to ask so that we may get the adequate answer for all the studies before we downgrade for inconsistency. Now, the next point is indirectness. Now, direct evidence comes from the research that is conducted in the populations or systems that are providing answers for, includes the intervention of interest and compares this intervention with the appropriate alternatives and measures the outcomes of interest. So the famous PICO criteria of population or patient, intervention, comparison or outcome, these give us the either the idea of the direct evidence, or if there are criteria mismatched, we can go for concluding that indirectness in the evidence is present. Now, indirectness means differences in population or patients, like high income countries, they are compared with low or middle income countries. For patients with HIV infection, if we take comparison for all patients, this is just an example of population or patients indirectness. Then indirectness for interventions would be if we take intervention class as new antibiotics and take comparator for old antibiotics, then inappropriate comparators like old antibiotics and no or other classes, outcomes like important outcomes versus surrogate outcomes, sign and symptoms for any particular disease to be compared with mortality of that disease. Now, when is evidence indirect for population? Let's take an example. A systematic review which asks what are the effects of self-management program in people with asthma. So here, in this particular study, let's say 5 out of 6 studies included people with severe asthma. Similarly, the question comes, do the results apply directly to people with mild asthma? Secondly, 4 out of 6 studies are in children aged 1 to 15 years. Now, do the results apply directly to the adults? All the studies are in women. Do the results apply directly to men as well? So all these questions will give you an idea about whether the population, for perspective of grade or grading of evidence, whether the questions are direct, whether the studies are direct, whether the evidence from the population is direct or not. Here in this particular example, there is indirectness present for the population. Now, if subgroups of the population are present, the intervention may have a different relative effect in each subgroup. A separate meta-analysis for relevant subgroups should be conducted. A separate summary of findings table should be created for subgroups. Now, consider creating one table if there is only one group, when there is no subgroup differences, present effects for only one subgroup, or describe the effect in the other subgroup in footnote or comments, and possibly downgrade for quality of evidence. Now, when evidence is indirect for intervention. So for indirect interventions, let's take an example again. What are the effects of cryotherapy in women diagnosed with cervical precancer? Now, consider the separate scenarios for recurrence of cervical precancers. In a similar study, 7 out of 15 studies were conducted before 1985, and new technology was introduced in cryotherapy equipment even 10 years after that. So does the evidence directly answer the question? Because intervention in these studies were supposed to be in 1985 or before. 8 out of 15 studies did not indicate if there were other co-interventions provided, for an example, prophylactic antibiotics or not. So again, the question is, does the evidence directly answer the question? 5 out of 15 studies showed cryotherapy was provided by nurses, and the other studies did not indicate the provider. So does the evidence directly answer the question? Now let's take an example of indirect comparisons. So we are interested in comparing drug A versus drug B. But what we have is drug A versus control and drug B versus control. These are the study results what we have. So it is indirectness in comparison. These are some examples of surrogate outcomes. Surrogate outcomes means indirect outcomes. For 2 to 3 months smear TB intervention, if we are taking cure from tuberculosis as outcomes, then for cholesterol intervention, if we are taking cardiovascular diseases as outcomes, for pulmonary function, health related quality of life, for cost of drugs, resource uses as surrogate outcomes, for HIV viral load, if morbidity due to HIV is considered as a comparative outcome or surrogate outcome, asymptomatic deep vein thrombosis, venous thromboembolism, so on and so forth. There are multiple examples where for any specific intervention, the surrogate outcomes may be or may have been used, but these show indirect outcomes and results, and they will be downgraded for their indirectness in the quality of evidence. When is indirectness serious or very serious? Means for downgrading, if very important difference in populations is found, it is serious indirectness, then downgrade by 1 level. If very large or impossible to determine differences in population is found, then it is very serious indirectness and downgrade by 2 levels. If difference in intervention or comparison sufficient to make a difference in outcome, then serious indirectness or downgrade by 1 level again. Or if very weak association between surrogates and patient outcomes is found, then downgrade by 2 levels. So if we see the summary of indirectness for downgrading quality of evidence, the indirectness is evaluated using the PICO format. surrogate outcomes with uncertain relation to patient important outcomes should either not be used or would lead to downgrading the quality of evidence from high to either moderate or low or very low. Now let's talk about the imprecision as a factor for downgrading the quality of evidence. We all know that precision is a consequence of sample size and number of events. And the indicators for imprecision is in general results are imprecise when studies include small population or sparse data, small number of events, and wide confidence intervals around the pooled effects, which includes the RR1. Now, in addition to describing how 95% confidence intervals should be used as the primary criteria to make judgments about imprecision, the optimal information size has been introduced as a second and necessary criteria for determining the adequate precision. So we will discuss with how to determine imprecision in studies with the confidence interval as well as the optimal information size. Now, if there is wide confidence intervals, then imprecision is there. By wide, what do we mean? That confidence intervals include both no effect and appreciable benefit and harm. For example, risk ratio of 0.75 or 1.25, either these sites. Now, what are the criteria to downgrade based on 95% confidence interval for imprecision? First, consider, does the confidence interval cross the clinical decision threshold or relative risk 1 line between recommending and not recommending the treatment? If the answer is yes, then rate down the imprecision irrespective of where the point estimate lie. If the threshold is not crossed, are the criteria of optimal information size met? Or is the event rate very low and the sample size is very large, at least 2000 or perhaps 4000 patients? If neither of the criteria is met, then rate down for imprecision. Now, what is this optimal information size? The optimal information size is applied as a rule according to the following. If the total number of patients included in a systematic review is less than the number of patients generated by conventional sample size calculation for a single adequately powered trial, considered rating down for imprecision. In this particular picture, the RRR is relative risk reduction, which is 1 minus the relative risk. Here, if the relative risk is 0.75 or 25% RRR, and the control event rate is 27 out of 100, the optimal information size was found to be 1200. For the total sample size to be met, the criteria or bar for OIS. This is a preformed table which actually shows for total number of events less than 100 or less, and relative risk reduction less than 30%, it is almost impossible, or we would never met the threshold of control event rate under OIS. So the minimum total number of events is required is 300 and 30% of relative risk reduction to meet the threshold level. It is the minimum of optimal information size or total number of events required. So the higher the number of events, the higher the number of sample size, then it is said that optimal information size is adequately met. Now here we will take some examples of narrow confidence intervals and optimal information size criteria met. Here we can see the treatment and control group patients numbers are high, and the relative risk or the estimated risk is 0.88, although it crosses the line of no risk or relative risk 1. Based on this criteria, as the information on the confidence intervals, it is very less, very narrow confidence intervals in the effect estimate, we will not downgrade for imprecision. Then narrow confidence intervals but fewer events. As we can see, the number of events is 69, 62. So as the total number of events are very less, or total events in this particular case, sorry, is 9 and 21. So because of this very low event rate, we will downgrade for imprecision. The only difference in these two, or the major difference in these two, is the event rates. Here the event rates are more, and here the event rates are low. Even though the narrow confidence intervals have been found, for lower event rates, the downgrading for imprecision is there for OIS based criteria. So the last criteria for downgrading the quality of evidence is based on publication bias, and it is a systematic under or overestimation of the effect due to selective publication of studies. It is also known as the file drawer problem, where faster and multiple publications for positive trials and fewer and slower publications for negative trials. Now, this slide shows the possible sources of publication bias throughout the publication process for the phases of research publications, preliminary and pilot studies, the report completion, journal selection, editorial consideration, peer review, author revision and resubmission, report publication. For all these stages of publication process, the publication bias may take place. Now, when should we suspect publication bias? Trials including large number of patients are less likely to remain unpublished or ignored and tend to provide more precise estimates of treatment effect, whether positive or negative. Now, risk of publication bias is probably higher for reviews that are based on small trials, and studies funded by industry are more likely to have outcomes that favor the sponsor. Now, grade approach to publication bias. Quality of evidence for an outcome will be downgraded depending on the seriousness of publication bias. If publication bias is undetected, there will be no change in the quality of evidence. If strongly suspected, then downgrade by 1 level. If very strongly suspected, then downgrade by 2 level. Now, this is a common or a symmetric funnel plot which shows a symmetrical distribution of the effect estimates, here in this case odds ratio and precision in the y-axis. This is an example of an asymmetrical funnel plot where the smaller estimates or studies with smaller estimates, they will be at the bottom. And asymmetric funnel plot, limited confidence in effect, therefore downgrade based on a funnel plot as well for publication bias. Now, high risk of publication bias example is a systematic review shows that pain was reduced when taking drug A compared to placebo, and small trials reported statistically significant benefits for drug A. A large trial showed a much smaller and a statistically non-significant effect, and smaller studies with smaller effects might not have been published. The effects is likely overestimated. So publication bias is likely a downgrade for quality of evidence. Now, when to downgrade because of suspicion of publication bias? Based on these criteria of study design, study size, lag bias for early publication of positive results, search strategy, and asymmetry in funnel plot, under these factors, various factors, publication biases can be suspected. Now, once we are through with the factors that downgrade the quality of evidence, let's talk about the factors which can upgrade the quality of evidence from its baseline or initial grading based on its study design. So first is large or very large effects that are less likely to be spurious. So if large effect is observed, upgrade for 1 level, and if very large effect is observed, then upgrade by 2 level. If evidence shows dose response gradient, then upgrade by 1 level. Or if effect observed as all possible residual confounding and biases would have reduced the effect, or if no effect is observed and all plausible residual confounding and biases would have increased the effect, then upgrade by one level. Now, what evidence can be upgraded? Primarily observational studies that are of low risk of bias, randomized trials that may have risk of bias not severe enough to preclude upgrading, and indirect randomized trials. Now, upgrading if large effect is present, upgrade by one level if relative risk reduction is 50% or more, or risk ratio is more than equal to 2. Now, upgrade by two levels if relative risk reduction is more than or equal to 80%, or risk ratio is more than or above 5. This is a common criteria. This is a common criteria everybody used to do badly, and now after the intervention, almost everyone is doing well. So if we find like these, then we can upgrade for large effects. Now, what evidence can be upgraded? Now the parachute used to prevent death. These do not need studies or comparisons. So these type of actually questions or research questions, their chances of upgrading, whatever the result they show, the chances of upgrading is always there, because we do not do randomized control trials for jumping from air, whether to use a parachute or not. We will not be doing comparisons or randomized control trials. So as per theoretical norms, their study designs will not be starting probably with higher results, but whatever the results is, if we see the practical aspect and the issues, parachutes have always saved lives. So for important outcomes in these sort of studies, we will always upgrade. So here the relative risk reduction is more than equal to 80% was the criteria for two levels upgradation. It is said that it is almost 99.9% saving lives in case of, or saving or from preventing mortality with the use of parachutes. So high confidence, high quality of evidence, and large effects is, or very large effect in this particular case is present. Therefore we will upgrade by two levels if even if non-randomized trials are present. Now, how upgrade if dose response relationship is present? Let's say an example: childhood lymphoblastic leukemia and risk of CNS malignancies after 15 years of irradiation. So if the radiation dose is like no radiation, 12 Gauss and 18 Gray, then CNS malignancy rates with 95% confidence intervals after no radiation for 15 years it is 1%, with 12 Gray it is 1.6%, and 18 Gray it is 3.3%. So constant dose response relation we have seen in this particular example. So we could upgrade the quality of evidence by one level. Now, upgrade if residual confounding and biases downgrade the quality. What is this? The confidence in results may increase when all plausible residual confounding and biases would have reduced the demonstrated effect, or all plausible residual confounding and biases would have increased the effect if actually there is no effect observed. Let's take an example of all plausible confounding would reduce the demonstrated effect. A systematic review of 11 observational studies revealed mortality or death cases in a non-profit hospital is less, for-profit hospital is more. But we would expect sicker patients and death would be higher in not-for-profit hospitals, but this did not occur. We would expect patients to be well insured and therefore more resources and fewer deaths in for-profit private hospitals, which did not occur. Therefore, we could upgrade because all plausible effects would have reduced the demonstrated effect. Similarly, taking the other example of all plausible confounding would reduce the demonstrated effect of unpublished systematic review on effect of condom use on HIV infection among men who have sex with men. 5 observational studies have shown relative risk of 0.34, and the non-condom user group, they have higher HIV infection, and with condom use, lower HIV infection. But the with condom use group had more partners, therefore would expect higher HIV infection and reduce the effect of the condom use. Therefore, we could upgrade because all plausible effects would have reduced the demonstrated effect. Now, up till this level, it is the job for the authors to be discussed with the summary of findings table for grading of grading of evidence. Now, those who are making guidelines or making recommendations for the agencies, for people, the grading of strength of recommendation is again of utmost importance. Now, grading the strength of recommendation, the degree of confidence that desirable effects of adherence to a recommendation outweighs the undesirable effect, and based on that, two sorts of recommendations are made. One is strong recommendation and another one is weak recommendation. Then weak recommendations are also called as conditional, discretionary, or qualified recommendations. What is strong recommendation? The panel is confident that desirable effects of adherence to a recommendation outweighs the undesirable effect. What is weak recommendation? The panel concludes that the desirable effect to adherence to a recommendation probably outweighs the undesirable effect, but not confident. There are certain terminologies in grade recommendations which are used. Passive voices may lack clarity of recommendation. Therefore, grade suggests the guideline developers to present recommendations in active voice. Such as for strong recommendations, the grade working group has suggested adopting terminologies as we recommend, or clinicians should, or clinicians should not, or do or don't. For weak recommendations, grade working groups have suggested less definitive wordings to be chosen, such as we suggest instead of we recommend, clinicians might instead of clinicians should, or we conditionally recommend, or we make a qualified recommendation that, such as these. And strong recommendations with the proverbs that we have previously discussed, it will be like early anticoagulations in patients with deep vein thrombosis for the prevention of pulmonary embolism. Another example, antibiotics for the treatment of community-acquired pneumonia, quitting smoking to prevent adverse consequences of tobacco smoke exposure, and use of bronchodilators in patients with known COPD. Now, what are the implications for strong and weak recommendation for different users of guidelines? For patients, if we see a strong recommendations, what patients would imply? Most individuals in this situation would want the recommended course of action and only a small proportion would not. If the patients see a weak recommendation, what they should imply is the majority of the individuals in this situation would want the suggested course of action, but many would not even. For clinicians, strong recommendations imply most individuals should receive the recommended course of action. Adherence to this recommendation according to the guideline could be used as a quality criterion or performance indicator, and formal decision aids are not likely to be needed to help individuals make decisions consistent with their values and preferences. Similarly, weaker recommendations for clinicians imply recognize that different choices will be appropriate for different patients and that you must help each patient arrive at a management decision consistent with their or his values and preferences. What is strong recommendation imply for policymakers? The recommendation can be adopted as policy in most situations, including for the use as performance indicators. And weak recommendations imply policymaking will require substantial debates and involvement of many stakeholders. Policies are also more likely to vary between regions, and performance indicator would have a focus on the fact that adequate deliberation about the management options has taken place. These are my references, which is Introduction to Grade, which is an online platform from Cochrane, and training videos and modules are available for this particular session, and from the Grade Handbook, which is available online again. Thank you so much.
Thank you, sir. Thanks a lot. Anyone like to ask some question?